Welcome to a new episode of Senefro25, a very special program being recorded during the 55th Congress of the Spanish Society of Nephrology in Oviedo. I'm Pepa Soler from Hospital Vall d'Hebron at Barcelona, and I'm the pleasure of having here with us Chema, that is sharing that with me. Welcome, Chema.
Thank you so much, Pepa. Thank you so much for our special guests. I'm very pleased to be here from Clínica Universidad Navarra in Pamplona, and thank you for this opportunity.
And we are here with Brad Robin from Ohio. Welcome, Dr. Robin.
It's my pleasure to be here. Thanks for inviting me.
And with Dr. Chi Kay from Leicester University.
Thank you for inviting me as well.
Okay, so Dr. Morales, when you want.
Thank you so much. And we are having the pleasure of visiting us from Ohio to Dr. Brad Robin, a worldwide expert. We recognize in many fields, especially in lupus nephritis. Dr. Brad Robin, a big question. Things are changing very rapidly and new therapies are coming up. So in these KDIGO guidelines, what are the future challenges that they will have to fear?
Yeah, so we are trying to keep pace with the new developments in glomerular disease, which is very exciting because for my entire career, we've had virtually nothing to treat our patients. And so one of the things we're going to do with the KDIGO is we're going to update probably for the diseases that are really moving quickly, like lupus and IgA nephropathy. We're going to probably have to update each year. And we're going to make the updates based on the new drug approvals and then the evidence behind them. So you'll start to see more frequent updates than we've had in the past.
Those are great news. And what is going to be the position of steroids in all this challenge, in this changing?
Yeah, I think, steroids are wonderful drugs, control inflammation very quickly. I think we are going to have a hard time getting away completely from steroids. I think we gave a menu of 3 different dose levels of steroids in the most recent lupus nephritis guideline, but I highlighted in today's talk my preference for the lower level of oral glucocorticoids with a modest induction with intravenous methylprednisolone. I think there's a lot of rationale behind it. We know that we can use lower dose oral steroids from several of the recent trials. And I think that the short burst of methylprednisolone helps control inflammation very quickly in those diseases, those varieties of lupus that are very inflammatory.
Thank you so much.
Thank you so much for coming and giving us an update of the new KDIGO guidelines of IgA nephropathy. So, what are the news? Did we modify when we now will be able to or is indicated to biopsy a patient with IgA nephropathy? Do you have a different range of proteinuria?
Yeah, so I think there have been several updates since 2021. And the exciting thing, as Brad has mentioned as well, is that there are several drugs that have now been approved or are coming for IgA nephropathy, which means that we now have a lot more tools to be able to treat our patients. So getting that diagnosis of IgA nephropathy and even earlier in the disease course becomes more important because there are things that we can do, medications that we can use to actually impact and treat our patients and alter that disease course.
And in terms of proteinuria, what is the moment to perform a kidney biopsy and what's the goal of proteinuria in these patients?
Yeah, so I think the guidelines have now suggested that we consider a kidney biopsy if patients have proteinuria above 0.5 gram per day, or if the kidney function is dropping and you're suspecting IgA nephropathy. So that's moved down from a previous threshold of around over a gram per day because we recognise from several registry studies from the UK RADAR study, but also registry studies from China, Germany, Sweden and others, that even patients with those lower levels of proteinuria are still at risk of progression.
For sure. So I'm thinking we need clinical trials in patients with lower proteinuria.
Yes, I agree. The difficulty is doing trials within a small time period, for example, 2 years. You do need to kind of enroll those patients who are at risk of progressing within that 2 years. But that doesn't mean those patients with lower levels of proteinuria are safe. So I do agree that group does need to be studied, and we need to think about how to enrich those studies for those higher risk patients.
Now that we have that amount of drugs, how will we deal? I'm thinking of my patients, which one I should decide which treatment is better for the patient.
Well, I think that's a good dilemma to have, because before we had nothing, didn't we? We had ACE inhibitors, now SGLT2 inhibitors, but now we have different drugs to be able to tailor to our patients. So I think we need to really carefully analyze the trial data and think about how we're going to use these tools in the future. But I think it's exciting times.
So, and in addition, as I was listening at you, we have to already update these new guidelines are for 1 month ago, and we have now new drugs, anti-complement drugs and new drugs. When do you think that we will have the new update?
Well, I think, as Brad says, it's probably going to be the existing guidelines they're out of date already. There are 2 drugs that have been approved that aren't in the IgA nephropathy guidelines. So I think you'll be working on those.
I think
right now.
We are monitoring this situation carefully, and I'm hopeful that we can get the work group to update this coming year. Yes, we have to do it. We have 2 new drugs and maybe a 3rd approval on the way next month. So it's been a lot, and so we want to keep current.
And further more to come, from the molecule to the cell.
Many more to come. Yeah, many more to come.
But actually, we are happy because before 12 years without modifying our guidelines, because we didn't have nothing for these patients with GN. So, for ending up, what is your recommendation for Brad, lupus nephritis, of the guideline? What do you more think that has changed, and for you, Chike, regarding IgA nephropathy?
So you want me to summarize what's changed in the guideline for lupus?
No.
All of that?
The landmark.
The landmark, I think, is that we're developing several immunologic regimens that actually have benefit beyond simply what a CRR is, a complete renal response, per a trial. These include regimens that reduce flare rate, and these stabilize GFR, maybe stabilize the podocyte, and hopefully in the future will stabilize fibrosis or reduce fibrosis. So I think our challenge and what we're trying to do is now think about how we can use the guidelines to individualize therapy. And I think that's our next major goal in the lupus part of the guidelines, is what's the right therapy for a particular patient at that time that you diagnose them.
Yeah, and for the IgA nephropathy, I think the real take-home messages are that it's not a benign disease. There's a very high lifetime risk of progressive kidney function decline and kidney failure. We need to address all aspects, including getting the proteinuria down as much as possible, slowing down that kidney function decline as much as possible, less than 1 ml per minute per year for the rest of that patient's life in order to prevent kidney failure. And we have to think about tackling the disease from both the immunological aspect and the CKD aspect as well.
I like very much all of that. So we are now at the end happy, and I'm seeing that in 10 years we will take a look at the progression of our patients with lupus nephritis, IgA nephropathy will be lower than is now. I have a question for Brad. Maintenance treatment in lupus, when is the moment of the maintenance treatment in lupus nephritis?
So we've blurred the lines between induction and maintenance, and I think the moment of the maintenance is when you start at the beginning, which is you start and you continue on what you're using. Now, I think as we get newer drugs, that may change a little bit. And I think we have to be a little bit creative with what we're doing. The B-cell drugs are really profoundly useful in lupus and lupus nephritis, and we're seeing that through the CAR T-cell therapy, deep elimination of B cells. So I think we're probably going to maintain patients with something that keeps the B cells under control, and that might be a little bit different than what we started out with, maybe depleting B cells at the beginning. But this is my idea. An idea of mine, an opinion, not evidence-based at this point.
And for TK, where will be the place of hematuria in IgA nephropathy?
Yes, so I think, as I mentioned in my talk, you can't come to Spain without mentioning hematuria. I think there's been some wonderful studies by the Glossen group demonstrating that patients with persistent hematuria are at higher risk of progressive kidney function decline compared to those without hematuria. But that's with the caveat that these were retrospective studies over a long period of time, but relatively small numbers, and the types of therapies that they had were probably quite mixed as well. So we definitely do need evidence to build on that work from prospective trials. So yes, a very hot topic, I think a matter for debate, and also think about which drugs we use in these patients. So far, interestingly, the trials haven't really shown differences in patients with hematuria or without hematuria in terms of response. So that I think that's a slight caution there.
And in addition, lower proteinuria, but also trials are trying the medications in lower GFR as well, as Pepa was saying in the question she did. So thank you so much. This is how the episode ends. Thanks to the special guest and thanks to the audience that have been following us on the Nephro podcast from Spotify, iVoox, and YouTube. And see you in the next episode. Thank you so much, Dr. Robin, Dr. Chige.
Thank you.
Thank you much.
Thank you for coming.